Hello.
Hello.
My name is Julio Porro, and I really want to thank you all for joining me today. I know how busy everyone is. And can we just take a moment, go around and introduce ourselves and the organization we work for? Very quickly, my name is Julio Porro. I'm kind of a pseudo-retired physician now, but for the last 17 years, I was medical director of a Medi-Cal managed care plan in, it's called Central California Alliance for Health in Santa Cruz, Monterey, and Merced County.
I'm an internal medicine doc, the director of high value care at CHCF and program officer for the fellowship and alumni.
Excellent. Welcome.
Thank you.
Kanoy Allen, Chief Nursing Officer for Hospitals for Children in Sacramento and Cohort 14.
I'm Lisa Alaferis. I'm a Senior Communications Officer at CHCF.
Great. Other people who'd like to introduce themselves who just came on?
Hi, I'm Ellen Chen. I'm calling in from the San Francisco Health Network.
Great, thank you. Anyone else?
Hello, this is Shira Shavit from the Transitions Clinic Network.
Right, welcome, Shira.
We're at CHCF Fellow.
Excellent. Anyone else? All right, well, let me jump in and get started. You know, I'm not really going to be talking about the 1115 waiver. I actually was asked at one of the last health equity groups to share a little bit of my work with the California Pan-Ethnic Health Network. Let me see if I can get this going. Yes. And working with their health equity work group. But some of the work actually does touch on both the state waivers as well as other ways of influencing both how Medicaid is administered here in California as well as covered California. Just a brief thing, again, when we talk about the 1115 waiver and that whole concept, as you know, federal law sets Medicaid minimum standards, but states do have flexibility. And the 1115 section in federal law allows for experimental pilot or demonstration projects for the states to actually do that. And I think currently there are about 33 states that operate at least one section 1115 waiver. So again, it's a way then for the state to both provide the minimum requirements that the feds are expecting, but also to try out new ways of being. So it is one of the ways, for example, that the state of California is able to do the managed care is under the 1115 waiver. So my story here is that, you know, being a health plan director, and before that being at community health centers, I was often really frustrated that health plans and community health centers oftentimes had to change course with whatever we were doing, addressing our local community's needs. We were then suddenly asked to pursue the latest state and federal requirement or pet project. And there really didn't seem to be any, you know, rhyme or reason to it. You know, with a new governor or different DHCS director or, you know, new federal mandate, all of a sudden there was a huge change in priorities, and all this really needed work was lost or ignored. And among that really is this notion of health equity and health disparities. I first tried to, just as a strategy within my health plan, I started joining every metrics committee that I could in and outside the organization to see if I can help create the right metrics. Then maybe, we can get them adopted and then really be pursuing the directions that we really wanted to. This new work that I've been doing with the California Pan-Ethnic Health Network really is addressing this notion of how do we try to institutionalize these broader efforts of what it is that we want to do. So how do we make it part of the bureaucracy so that advancing health equity, decreasing health disparities becomes not something that we do when we have the time, priority number 12, but how do we institutionalize it so it actually becomes a requirement for different programs? So this is what interested me about this work group. And I'm trying to move this. Oops. Okay, here we go. So CPAN has been very involved over the years, and I think it's funded by CHCF in 2001 and really been involved in the healthy families and mental health and lots of different types of similar efforts over the years. So I actually took about 150 slides. I want to thank Carrie Sanders, who's a senior policy director at CPAN, for 150 slides. I actually brought it down to about 25. I'm hoping to have this presentation be 20, 25 minutes long, and then I'd love everyone's input. But the clear thing with health equity, we know that the ACA focuses on triple aim: improving health, lowering costs, better care. But where is disparities? And one of the interesting things, this map on the right actually looks at the average differences in quality of care for Blacks, Hispanics, and Asians compared with whites by state 2014 to 2015. And you can see the darker colors. There's four quartile difference in how badly or how different the disparities is. There is, just wanted to share, whoops. I think California looked at maternal mortality rates between 1993 and 2013 and noted that even though rates improved for Blacks and in relation to Hispanics and whites, by the end of those 13 or 14 years, the disparity remained the same. So there was the same level of decrease, of course, for all of those groups, and the disparity remained. One positive piece, Kaiser did a study and actually gathered both individual data for their health population, looking at different ethnicity groups, and they developed very specific strategies to address, again, they call it individualized equitable care, specific strategies for each of the groups to actually address the disparities. So as part of CPAN's strategy and my involvement with the work group, the initial piece was for CPAN to better understand the healthcare system and the reform opportunities. Next, gathering feedback through focus groups and through the work group. Conduct research on developing policy proposals and incorporating ideas from the different work groups. And then looking at short-term reform opportunities. How do we influence the Section 1115 waiver for Medi-Cal, the Section 1915B waiver for Medi-Cal behavioral health? How do we impact covered California health plans? And then finally, how can we develop a set of recommendations and guiding principles for long-term California health reform that advance health equity. Oopsies. So I won't spend very much time on these. This is a list of some of the focus groups that were enlisted through the consumer piece. And recommendations really centered around, again, this is just, there's a lot of slides for each of these topics, and I can certainly share those slides with you all. But data, navigation and coordination care, cultural and linguistics interpretation and translation, accountability, access, and respect. Again, these were the things that the focus groups were really wanting to see at the direct patient care area. So the Health Equity Regional Work Group, we started off looking at the 1115 and 1915 waiver renewals, and part of the questions were, are there other what's happening in other states, and are there creative ways of advancing health equity and addressing social determinants of health in other states? Other questions, of course, how, what are effective strategies for elevating consumer voices, and how do we ensure as well that mental health practices are integrated into payment and delivery reform? So a waiver concept paper was released in fall of 2019, and there were ongoing discussions and after that came out. For the Covered California piece, there's a concept, don't know if you've heard of it, of a qualified health plan. So in order for a health plan, like a Health Net or Blue Cross, to offer a Covered California product, it actually needs to meet certain requirements. It falls under the, again, it becomes a qualified health plan. So the question here was, how can we influence what the requirements for a qualified health plan would be? How do we influence health plans to do that so that they can then, it's required of them and it's required of whatever physician groups, physicians contract with them. So what are the immediate next steps that Covered California can take to expand the disparities, provision, and again, how do we leverage that Covered California funding to address social determinants of health? The work group came up with a couple of areas where we really thought needed attention. One is workforce diversity. Other was just community-defined practices, especially in mental health. Again, social determinants of health and how to incorporate that piece. And then finally, how to leverage payment and delivery reform strategies to better integrate safety net providers into systems of care. The barriers to the access care. Again, the question of what metrics are we going to use? What are the appropriate benchmarks? And what do other states use? And are these metrics really disparities sensitive? The workforce issue, how do we increase diversity? How do we address funding for community health workers, care coordinators, and similar workers? Mental health, and again, I'm just sort of summarizing very quickly each. How do we strengthen the whole mild to moderate mental health care services? When I was at the Alliance, we saw really low utilization of mild to moderate mental health care. But we also talked to a lot of our providers who were at the same time saying there's not enough mental health providers out there to see our patients in a timely way. So again, better understanding, why were we seeing very, very low utilization? Was it did our providers know about who they needed to contact, whether they needed to contact a plan, or what the problem there was. And finally, we don't talk about it much, certainly not in the Medi-Cal health plan piece, but really the importance of oral health and how can we bring that and integrate it into the delivery system. So again, I mentioned the Covered California and some of the requirements. Most recently, some of the work that I've looked at, I think just in the last couple of weeks, is this notion of data collection. Again, we don't know how critical certain problems are until we really get very, very good data. I think in 2017, there were 9 of 11 of the qualified health providers who actually saw an increase in the self-identification rate over 2015. But, in addition to the REL, the race, ethnicity, language, how do we continue to push the SOGI criteria, sexual orientation and gender identity, as part of those collection efforts. So again, this is sort of a summary again of what CPAN was trying to do. Again, identifying opportunities, getting input, developing recommendations and analyzing some findings, and then creating the policy roadmap. So from the work group, these were the top 6 areas that we looked at on the top 6 strategies on achieving health equity or improving health equity. And what I'm going to do very quickly with the next 6 slides, and this is, I'm not sure how fast I'm going, is just going to highlight some of these and examples of some of these. So first off, improving self-reported data collection by race, ethnicity, and other social demographic factors. 1, strengthening the CNL competent care. 3, investing primary care, strengthening care coordination, improving patient engagement, and addressing social determinants. So what are some of the specific strategies? So again, with the data collection piece, needing to strengthen both the reporting and the accountability for the Attachment 7 requirements for Covered California. Making sure that SOGI, and I've talked to folks in the field, and they do share that some of this information is really, really difficult to get, mostly because of EHR systems or claim systems that really are not set up to capture this information. But we need this information in order to better target and identify those disparities. The strengthening access to culturally and linguistically competent care. Many communities, as you know, we've heard this in our groups, the use of community health workers, but more and more we've been using community-based navigators. Certainly incentivizing the adoption of patient-centered medical homes. I believe Oregon, 90% of their patients actually are connected to patient-centered medical homes, and that's all based on extra funding, I believe. And then the other piece, of course, is making sure that trauma-informed care and implicit bias training is part of, is included for providers who contract with qualified health plans. Or even possibly looking at it as a bonus payment for completion. So as specific providers go through this themselves within their system, the qualified health plan would provide them a bonus payment for completion of it. Investing in primary care, again, incentivizing the adoption of patient-centered medical homes, getting baseline on the percentage of providers contracting with the qualified health plans. Again, this is in the covered California world. And then setting specific targets for achievement. And finally, encouraging qualified health plans to enter into alternative payment models with safety net providers for enhanced primary care. The next strategy, again, which has been included in our recommendations, is improving care coordination around physical, dental, and mental health, and requiring PCPs to report on process measures that show that there's integration going on. The improving patient engagement through Covered California, requiring that health plans create community advisory councils that are representative of the population that they serve. And these councils would be able to review survey results, be involved in drafting community health needs assessments and equity plans, as well as identifying interventions to strengthen quality and performance outcome. I should say that one of my frustrations in many of the health plans, both that I've worked at and know about, is many of them, even though they have member advisory groups, the organization that I worked with, for example, had a member advisory group, but there were no members that were part of that advisory group. It was all representatives of organizations that advocate for members, but there weren't any actual members on it. I think that's certainly changed with some of the changes that have occurred recently. So I see a little bit of movement, but there are, I think, health plans around the country that have shown that it can be done efficiently, appropriately. I'm thinking of Virginia Mason up in Seattle and Intermountain in Utah. Finally, addressing the health determinants of health, requiring qualified health plans to screen patients for social needs, conducting local and regional community health assessments, and submitting data on the social determinants of health, and making investments to address them. So that was a very, very quick view of a little bit that I've been doing with CPAN. I think I wanted to spend a good amount of time getting some of your thoughts and questions about these efforts. The particular work group that I'm involved in is a 2-year effort. I'm like halfway through, and I think initially we worked on the 1115 waiver, and I can share with you a couple of other very specific suggestions that we had, and the mental health waiver. The most recent thing, again, is on data collection. I'm curious from you all as well, what other areas are ripe for inclusion in these kinds of efforts? And, what other strategies do you have to actually institutionalize sort of this health equity issue into our organizations at the federal, state, health plan, health center level? So I'm opening it up to you all. Any questions?
Julio, thanks for presenting. This is Ellen. Hi. As I'm listening, and as we've been tracking all the emerging developments for Healthier California for All.
Yes.
And particularly the population health management part of that. A lot of detail hasn't emerged there in terms of how things will get done, but there is definitely a lot of talk around how the health plans will need to do risk assessments and screening for social determinants of health. And I'm wondering how but I haven't heard a lot of conversations specifically around how they're going to incorporate equity issues in that risk tiering and the programs. Do you have any information around that?
You know, I don't, and again, I'm glad that you're, bringing that up. That shooting for particular goals or particular metrics does not necessarily mean that you're addressing the disparities piece. I think, unfortunately, where we're at with CPAN really goes back to making sure that we're getting adequate data, so that then we can try to figure out, okay, how do we measure disparity sensitive measures. So I don't have any. Does anybody else have any thoughts or ideas about that?
Hi, this is Shira. I'm not sure I can necessarily answer that the question I think that Ellen was asking, but I think one thing I just wanted to add, kind of thinking about the data collection pieces, my work is very much focused on the kind of intersection between the criminal justice system and the health system. And what I have found in talking with plans is they're not routinely collecting any information about people's criminal justice involvement. So I think if we're looking at this from a health equity lens, that should be something that should be on the radar of the health plans in assessing that impact on the patients they serve, and then from there being able to address specific needs related to that.
Great, thank you. I appreciate that. I shared with CPAN that I was going to be presenting this information to the larger CHCF equity group, and they were very, very interested to hear what you all thought and whether there were any specific areas that you thought that we were missing. And I appreciate. I think the criminal justice piece is a really, really important element.
Yeah, I mean, because I think oftentimes, I'll talk to a plan and then talk about the work we're doing, and they're just kind of like, oh, well, we don't think this impacts our members, or you tell us how this impacts our members. And I think we also have a lot of difficulty getting data, from the state, having good linkages between the criminal justice system and the health system to really understand impacts of programs across those two systems and kind of what these numbers look like. But I think if the plans routinely screen patients, we would definitely have some really good information.
Yes.
Leah, this is Michelle from CHF. Thank you so much. This is really interesting and important work. Having been at a plan, I'm curious what you think, you know from your experience how hard it is to get data from membership, right? How
Yes.
Assessments for seniors and people with disabilities, plans don't do a terrific job getting great return on those and the important information that's in them. So have you thought about how to help plans improve their quality in getting this type of information?
Yeah, it's fascinating, and I think I alluded to it a little bit earlier, which is, the health plan that I worked with, I should say, is an incredibly high functioning plan. It's one of the top plans in the state as far as quality, HEDIS measures and all this other stuff. And it really feels like, the Wizard of Oz sometimes, where, the the rest of the world might see an incredibly high functioning organization, but behind the scenes, you see where all the duct tape and the steam coming out of the pipes and people trying to keep it together. That's actually what health plans look like, unfortunately, a lot of the time, and especially around data. 17 years at this health plan, and in some ways still asking for the same types of data on year 17 that I realized we needed in year 2 or 3. So the one thing that we have, and I think most health plans, perhaps it's different for commercial health plans who have unlimited amounts of resources, or it feels like. But if the state, if there is a new, let's just give the example, Governor Newsom is really interested in children's health measures, then and is suddenly requiring specific types of data back. A lot of health plans will push back, but for the most part, they will dedicate whatever resources they have. They will move heaven and earth in order to be able to get that data and provide that data. Of course, every other effort, data collection effort in the organization then does suffer tremendously. But health plans generally will find a way of moving their system to provide the data that's required of them. It's just a reality in the health plan. At our health plan, there was, we did a health disparities, interestingly enough, we did a health disparities initiative around opioid deaths and Narcan use. And it was more a rural versus urban/suburban county. We were noticing huge number of opioid deaths in Merced County, going up compared to Santa Cruz County. And we found that we actually just did not have very good data from the state claims, that we actually had to create our own system. And I think we were just very, very lucky. We were assigned, 1 or 2 IT people, and we met on a pretty dedicated basis and were able to create this great data collection tool so that we knew where we got information from pharmacy, from carve-out data from the state, claims data internally, and being able to piece everything together to actually ask some real questions and be able to guide our efforts with Narcan use in this county, Merced County. So, occasionally health plans will have a small amount of leeway to be able to create the data infrastructure to pursue something interesting and locally important. But most of the time, I'd say 90 to 95% of the efforts are to meet the requirements from the feds or the state. So sorry, that was a little long-winded.
No, thank you. Appreciate it.
Other other strategies to, again, in our groups, our CHCF groups, to talk about health equity. What else can we do to make sure that this is not, priority number 11 or 12? For our organizations.
Julio, this is Kanoi. I sit on the committee work group for the events that we have, the biannual CHCF alumni weekends. And maybe you and I offline can talk about this, because I think one of the things we wanted to do a couple years ago was to really start the discussion on equity.
Yes.
And bring that forth. And I personally don't want to stop it, and those of us on the work group don't want to stop it, but we also want to learn more about how to advocate and to most effectively present ourselves, as well as to support policy and access and all of those great things. I'm just sitting here listening to your presentation. I'm going, oh my gosh, I'm floored. There's just so much to do. But maybe you and I can talk offline about how we can continue to thread this through our ongoing discussions at the weekend events, and how we can shape this to keep it at the forefront for everyone, as well as bringing in other agenda items.
That sounds good.
Yes, because I also have a discussion going on with someone called Jen Hastings. So I think there's a lot of work.
All right. Yeah, I'll share just one last thing that occurred to me, sort of a recommendation that I and some of the other work group members had early on, and again, to address how to make health disparities a higher priority. And my suggestion was, at the state level, at DHCS, to actually have somebody, a director position, around health equity, whose sole job was to make sure that efforts were being advanced around health disparities. Again, with the thinking that if someone and/or a part of an organization is not made directly responsible for these efforts, then unfortunately, it becomes everybody's and it becomes nobody's. So nobody becomes accountable for specific advancement around health equity. So creating a director level position at DHCS and/or equivalent places where this is the sole issue that they're involved in. Okay. Well, this may be a shorter session than you all were expecting. I'm happy to send out these slides and even more expanded slides, as well as some information on 1115 waivers, if that's of interest to people. Any final thoughts or questions?
Thanks, Julio.
Okay, well, thank you all.